Alaikum. So I hope all of you are doing okay. Yesterday I gave you a task, so please make sure that you complete it. You complete this assignment and submit it to me by Monday. So you have to write down the history of diabetes mellitus. How does the diabetes mellitus get its name? And differences between the type 1 and type 2 diabetes, and differences between diabetes mellitus and diabetes insipidus. So you have to submit it by 22nd of this month. Now we're going to study the pathophysiology of diabetes mellitus. So let's get on with it. Let's study the pathophysiology of diabetes. So in diabetes there are two pathways or two different disorders that could occur. The first is absolute deficiency of insulin, that is type 1 diabetes mellitus, when no more insulin is being produced due to destruction of beta cells or fibers of Langerhans in the pancreas. And the second is type 2 diabetes, where there is relative deficiency of insulin, that is insulin is still being produced, but it is either not being produced in the adequate amount, or insulin resistance has developed. So what would happen is there would be some short-term complications and some long-term complications, and there would be some mild signs and symptoms and some severe signs and symptoms that could occur. So we're going to discuss all of these one by one. So what happens if there is abnormal metabolism of different products due to deficiency or insulin resistance? So it would cause increased breakdown of proteins or proteolysis in huge amounts, larger amounts, and these proteins would be used to produce new glucose in the liver, that is gluconeogenesis. That would increase the hepatic output of glucose or increase production of glucose in the liver. This would also cause glycogenolysis, that is breaking down of glycogen, that is a stored form of glucose in the liver, and that would also eventually lead to increased hepatic output of the liver. Moreover, there would be decreased glucose uptake by the tissues which are dependent on insulin for the glucose uptake. We've already studied these tissues: the cardiac tissue, the resting skeletal muscle, etc. So what would happen is there would be decreased glucose uptake, and all of these, the increased hepatic output of glucose and decreased glucose uptake by tissues, would eventually lead to hyperglycemia. Hyperglycemia, that is increased sugar levels, glucose levels in blood, would lead to fatigue, that is the patient would feel weakened, would feel pains in his whole body, in the muscles, etc. Moreover, there would be increased diabetes excretion in the urine, that is known as glycosuria. So when there is increased glucose that needs to be excreted out by urine, the kidneys have to work more, produce more urine, and that would cause frequent maturation, frequent urination, which is known as osmotic diuresis. What happens is osmotic diuresis. In osmotic diuresis is there is increased concentration of glucose in the blood. That's why blood would get hyperosmolar, more thickened. The kidneys have this function where they have to control the concentration of different products in the urine. If the patient is getting hypoosmolar, they would conserve more water. But if the urine is getting hyperosmolar, if the blood is getting thicker, hypoosmolar, kidneys would excrete more and more of that product into the urine. And while excreting glucose in the urine, they would also excrete uh, more water in the urine. They would produce more urine. Production of more urine by the kidneys is known as diuresis. Frequent urination, excess urination is diuresis. So osmotic diuresis would occur. That is production of more urine via kidneys due to hyperosmolarity of the blood. This would cause polyuria and polydipsia. That is frequent urination. If you go to washroom, if a normal person goes to washroom 3 or 4 times a day, a diabetic would go 10 to 12 times a day. Normal production of urine throughout a day 24 hours is about 2 to 2.5 ml, 2 to 2.5 liters of urine, whereas a diabetic may produce up to 4 to 5 liters of urine. And if he is excreting so much urine, he needs to maintain the water level, the solvent level in his blood. That is why he is going to drink water more frequently. So he would have a sign that is polydipsia. Polydipsia is when the patient is always thirsty. He keeps on drinking more and more water and keeps on producing more and more urine. So polyuria and polydipsia cycle would occur. Moreover, in diabetes, there is another thing that is known as polyphagia. That is, patient would need to eat the food again and again after small breaks. So polyphagia, polydipsia, polyuria are signs of diabetes mellitus. So if more urine is being produced, there would be more excretion of salt and water in the urine. That could cause hypotension or decreased blood pressure. And this hypotension, if severe, can lead to death due to shock, hypovolemic shock, and then death. So if there is no more diabetes being produced, this is especially seen in type 1 diabetic patients. The If there is no more insulin being produced, there is no insulin at all in type 1 diabetes patients before we start the treatment. So there would be increased lipolysis, increased breakdown of fat in the body. This fat, when it is broken down, would leave a byproduct that is known as free fatty acid. So there would be increased free fatty acid in the plasma. Now, if the insulin is present, it would first suppress the lipolysis, the breakdown of fat, plus it would increase the uptake of free fatty acids into the adipose tissue. But if insulin is not present at all, these free fatty acids would keep on circulating in the blood, in the plasma. And to eliminate these free fatty acids, liver would take up the job and break down these free fatty acids to produce ketones, acetone, etc., 17 keto acids, etc. So liver would break down these free fatty acids into ketones, and when there are increased ketones in the blood due to breakdown by the liver, this condition would be known as ketoacidosis. This is an acute emergency that could be seen in type 1 diabetic patients. The complete name is DKA, diabetic ketoacidosis, which is an acute and severe form of diabetic emergency, and if not treated, it would lead to death. Then there could be long-term complications of diabetes mellitus. These are divided into macrovascular and microvascular complications. Macrovascular are complications which occur due to larger vessels, such as the blood vessels that are supplying brain or blood vessels which are supplying the heart. They start getting clogged, blocked. So in addition to hyperglycemia, there is hypercholesterolemia in a diabetic patient, increased free fatty acids in a diabetic patient. This cholesterol would start building up in the smaller as well as larger vessels. So when this cholesterol builds up in larger vessels, the lumens get thinner and thinner. There is less and less space for blood to travel into the end organ. When this lumen is blocked up to 90%, then due to any stress during exercise, during running, during periods of uh, psychological stress, or vital organs such as the heart and the brain, they need more blood, they need more oxygen. So when the demand of oxygen would get high, more blood would try to get pumped through the arteries of the heart and the brain. But there is the lumen of the blood vessels is already 90% blocked, so it cannot handle any more blood passing through it. So what would happen is, due to an acute episode of stress, the blood supply of that particular organ would be compromised. Our body would not be able to compensate for the missing oxygen and would not be able to provide adequate blood to that organ. So what would happen? Tissue damage would start due to decreased oxygen supply. That is known as tissue ischemia, cardiac ischemia, or cerebral ischemia or infarction. Moreover, a clot formation could occur in hyperosmolar state, and that could go and block a blood vessel. That would also occur. So when there is tissue ischemia and the reperfusion is not started, the blood is not again supplied to that tissue. Within a few minutes, the tissue starts to die. That is known as infarction. In the case of uh, heart, that is known as myocardial infarction, or simply put, heart attack. And in case of brain, that is known as cerebral infarction or cerebral ischemia, and simply put, it is known as stroke, जिसे फॉलेज कहते हैं. ठीक है. Then there are microvascular complications that are sometimes what happens is our nerves and the end organs such as the fingers, such as the nerves that are present in fingers, such as our retina, eyeball, these are supplied by very minute capillaries, very small blood vessels. So when there is hyperosmolarity, these vessels can get clogged, blocked easily. And over time, this blockage in the end organs, such as the eye, such as the kidneys, such as the nerves, these tissues start to get ischemic, and then these tissues start dying. So long-term complications of diabetes would be retinopathy, or blurriness of vision would occur, and then the patient may lose his vision completely. तो अगर आप देखें तो many diabetic patients, they complain that over the period of 5 years or 10 years I've been losing my vision. मुझे सही से नज़र नहीं आता, धुंधला नज़र आता. That depicts that the patient is undergoing diabetic retinopathy. Moreover, there would be decreased function of the kidneys, that is known as diabetic nephropathy. Kidneys have been handling the excess glucose for years and years, and after 5 or 10 or 15 years, they start to lose their compensatory function. They start getting damaged, and that would increase creatinine, that could lead to renal failure. Kidneys काम करना छोड़ सकती हैं. The patient, we may have to put the patient on dialysis. And that condition would be known as diabetic nephropathy. The peripheral neuropathy is often seen in diabetes, where the patient lose uh, senses in the fingers and toes, in the hands and feet. So पेशेंट को कुछ महसूस नहीं होता इन द हैंड्स एंड फीट. सेंसरी जो है nerves, they get destroyed due to blockade of the minute blood vessels that are supposed to supply those nerves. These are known as nervi urgenti, and they get blocked after an extended period of hyperglycemia. So peripheral neuropathy is another long-term complication of the diabetes. Now, how do we diagnose the diabetes? Diabetes is diagnosed via two strategies. First, we look at the clinical picture or clinical features of the patient, and then lab diagnosis also helps in diagnosing the diabetes mellitus. So what would be clinical features of the diabetes? There would be some central features and then peripheral features. And central features include polydipsia, polyphagia, lethargy, and stupor. Polydipsia means increased thirst. Patient would drink water again and again. Then polyphagia, patient would feel as if he is hungry all the time. He would keep on eating because there are no more glycogen stores. Has on all already been glycogen stores have already been used. So that's why during the periods of starvation, the patient would start getting hypoglycemic and he would feel the need to eat. He would be starving all the time, hungry all the time. Patient would feel lethargic as if there is no energy in the body, and sometimes stupor may occur. Stupor is when hypoglycemia or extreme hyperglycemia, more than 600 milligram per deciliter sugar, is present in a patient. The patient can undergo a coma-like state. He would be awake, opening his eyes, but would not be able to understand the thing or follow your commands or anything. This is known as stupor. So lethargy and stupor are more common in type 1 diabetes than type 2 diabetes, because in type 1 diabetes the patient is already very thin and lean, and most of the time it is a child. So there are no glycogen stores in the liver, there are no fat deposits in the muscles, so the patient would not be able to produce energy from there. That's why these conditions would mostly be seen in type 1 diabetes. Weight loss can be seen. This is also more common in type 1, but it could occur in type 2 diabetes. And respiratory problems could occur, such as the Kussmaul breathing. Kussmaul breathing is hyperventilatory breathing. Due to decreased insulin or insulin resistance, free fatty acids are being converted into ketones. These ketones would make the blood acidotic. So, diabetic acidosis, as we studied it. This can also be elicited by the kidney. If the kidney function is decreased, hydrogen ion would not be excreted and acidosis would start developing, which is known as metabolic acidosis. To compensate for that, kidney lungs would try to expirate, pump out more carbon dioxide from the body so that they could neutralize the acidosis in the body. So hyperventilation would occur, that is known as Kussmaul breathing. Blurred visions in eyes could occur, that is more common in type 2. This occurs due to long-term complication, that is diabetic retinopathy. The breath may smell of acetone, may smell of nail polish remover. If you have the experience of smelling the nail polish remover during the periods of increased glucose or hyperglycemic periods, and when insulin is decreased, the ketone bodies, they would make the smell of the breath of the patient same as that of acetone. So acidotic breathing can be seen. There can be some gastric upsets such as nausea, vomiting, and abdominal pain. These are also more common in type 1 diabetes. And then there is polyuria and glycosuria in the urinary system. That is frequent maturation, frequent urination, and urination in large amounts, and presence of glucose in the urine. Now these were the clinical features. Now let's look at how can we diagnose diabetes in a laboratory or during via lab tests. So we may check the urinary glucose and ketone bodies level, fasting blood glucose, and the gold standard, that is glucose tolerance test or oral glucose tolerance test. To check the urinary glucose level, we obtain the urine sample, send it to laboratory. So if blood glucose level is increased above the renal threshold that appears in the urine, which is known as glycosuria, our kidneys are able to process the glucose up to a certain extent. They are normal persons kidneys, they retain the glucose, they do not let the glucose escape the body. But if that threshold, that limit is reached and glucose is in larger amounts than we need in the body, the kidneys will start excreting this glucose in the urine. That is known as glycosuria. And different tests like Benedict test or dipstick test can be used to diagnose glycosuria. Urinary ketone bodies can be tested by Rothera's test or dipstick test. You don't need to remember the names of these tests, just what we check for a diabetic patient. So let's continue with the lab diagnosis. We may also check fasting blood glucose level and glucose tolerance test. So what we do is we starve the patient for 6 to 8 hours. That is, the patient is not allowed to eat anything, only drink water after 12 p.m. at night, and at 8 in the morning we check the glucose level of the patient while he is still hungry, means he has still not eaten anything. The fasting blood glucose level in the early morning is normally 82 to 110 milligram per deciliter, that is 4.4 to 6.1 millimole per liter. A fasting blood glucose level above this value often indicates diabetes mellitus. Now the thing is, 111 to 125 is known as pre-diabetic, whereas more than 126 would be known as diabetic. A fasting blood glucose level above this value often indicates diabetes. So there's that. Now oral glucose tolerance test. So what do? We unrestrict the carbohydrate diet for 3 days before the test. We make the patient eat whatever he or she wants for 3 days straight. Then the normal diet, we ask the patient to take the normal diet for 3 days. Then we fast him or her overnight, that is from 12 p.m. till 8 a.m. for at least 8 hours. And then we ask the patient to rest for 30 minutes before the test and cannot smoke or be seated and the patient cannot smoke before the test. Patient cannot be seated during the test. We may ask the patient to lie down or sit up. Well, lying down is better. Then the plasma glucose is measured while fasting. Then we give 75 ml of glucose in 1 glass of water and ask the patient to drink it whole. Then we measure the blood plasma glucose level after 1 hour and then after 2 hours. So how do we interpret these results? So at fasting, if the plasma glucose level is less than 126, and after 2 hours it is less than uh, I think it is 180. We say the patient is not suffering from diabetes. I'll send you this chart, okay, and you can look at it. So after 2 hours, uh, if the plasma glucose while fasting was more than 126, sorry, was between 110 to 126, and after 2 hours it is less than 180, we say the patient has impaired glucose fasting level, but it is pre-diabetic. The patient is pre-diabetic. If the two values, the thing is, if one value is abnormal and the other is normal, then we say it is impaired glucose tolerance or impaired fasting glucose, depending on the abnormal value. If the fasting value was more, but after 2 hours the value gets normal, then it is impaired fasting glucose. And if the fasting value is normal, but after 2 hours the value gets more than 180, we say it is uh, impaired glucose tolerance. And if both of the values are more than our criteria, we say the patient is diabetic. So here it is. After 1 hour, a normal person's sugar should be at about this level, 120, 130, and after 2 hours it would get normal. But a diabetic patient would have more than 180 milligram per deciliter sugar in his or her blood after 2 hours. Now, the classical symptom. Let's look at the diagnostic criteria for the diabetes mellitus. So the classical symptoms and casual blood glucose level, if more than 200 or 11.1 millimole per liter uh, blood glucose, plasma glucose level, along with clinical signs and symptoms, we would say the patient is diabetic. If the fasting blood glucose level is more than 126 milligram per deciliter, we may say the patient is diabetic. If oral glucose tolerance test with blood glucose after 2 hours at more than 200, or we say more than 180, we'd say the patient has diabetes. So these are the three criteria on which we judge the diabetic patients. So plasma glucose values, plasma blood glucose values are given above, and we should check the patient at least twice for all the three criteria to nominate him or her as a diabetic patient. Now let's look at some other scenarios. So let's talk about insulinoma or hyperinsulinism. So what is it? Hyperinsulinism is when excessive insulin is being produced occasionally from a benign tumor of islets of Langerhans. About Only about 10 to 15% of these tumors are malignant, mostly they are benign. So in hyperinsulinism, there would be increased insulin production by a tumor of the islet cells. Hyperinsulinism would lead to hypoglycemic and insulinic shock. Due to higher levels of insulin in the blood, the patient would always have lower blood glucose level than the normal, and the blood glucose would fall to such an extent that the glucose metabolism in the central nervous system would get disrupted. The central nervous system would not be able to survive anymore, and the patient may die due to hypoglycemic shock. So the features that can be seen in hypoglycemia, that is decreased blood glucose level, are initially the patient would be extremely nervous, would be trembling, कांप रहा होगा, and sweating is seen. Later on, if we do not replenish the glucose stores, what would happen? The patient may undergo seizures, झटके लगना शुरू हो सकते हैं. There can be loss of consciousness, or the patient may undergo a state of coma. So these are severe complications which may cause death in a patient. So how will we differentiate hypoglycemic and hyperglycemic coma? Because in both patients, the patient would be unresponsive. How would we able to predict that if it is hypoglycemia or hyperglycemia? So clinically, if there is hyperglycemia, the breath would be acidotic and hyperventilatory, rapid breathing and deep breathing. Whereas in hypoglycemia coma, the breathing rate would be normal. So clinically, this is the first point on which we can differentiate between the two. Moreover, we can conduct lab tests, the blood glucose level and the ketone bodies. Ketone bodies are only present in hyperglycemic patient, they are not present in hypoglycemic. Moreover, blood glucose level would be increased in hyperglycemia, whereas it would be decreased in hypoglycemia. So now let's look at a summary of insulin related pathophysiological states. In type 2 diabetes mellitus, there would be increased blood glucose level. As we know, insulin may be normal or insulin level may be increased, and the C peptide would follow this trend of the insulin. And ketoacidosis is not present because the insulin is still being produced in the body, or it is still present in the body. Whereas in type 1 diabetes mellitus, glucose would be high, insulin would be low, C peptide would be low, and ketoacidosis can occur. It can be present. In insulinomas, glucose level is low, there is hypoglycemia. Insulin is high and C-peptide level is high and there is no ketoacidosis. Whereas in factitious hypoglycemia, that is if the patient is self-injecting himself or herself with insulin, what can we see is glucose level would be low due to excessive insulin being injected. It would be hypoglycemia. There would be increased insulin level in the blood, but there would be no C peptides, lower quantity of C peptides, because C peptides are only produced in beta cells. So the insulin produced in beta cells would have equal values of C peptide, but if insulin is being taken from outside, the C peptide level would be either normal or lower than the insulin level, and ketoacidosis cannot be present in this patient. So this marks the end for diabetes mellitus and the endocrinology in general. So I would see you guys tomorrow inshallah, and we'll start new topic. Thank you, take care, Allah Hafiz.